In this video, I'll go through some basic facts about a serious kidney disease known as nephrotic syndrome. The disease is due to extreme proteinuria, and it is defined by 3 essential criteria. First, an extreme proteinuria with an albumin-creatinine ratio of more than 2,200. Secondly, the occurrence of generalized edemas, and thirdly, very low levels of plasma albumin of less than 25 grams per liter. The disease is characterized by rather sudden onsets of severe proteinuria. This can usually be treated pharmacologically with corticosteroids with the aim to bring the child into remission. Approximately 30 new cases per year are affected with nephrotic syndrome in Denmark. The median age of onset is around 3 years, and it is twice as common in boys than in girls. Almost all cases are idiopathic, with no underlying disease together with the nephrotic syndrome. In rare cases, the nephrotic syndrome is secondary to other diseases such as diabetes mellitus, infections, drugs, and malignancies. The pathogenesis is still unknown, but it is clearly related to dysfunction of the immune system, and it may be a primary T-cell disorder. Also, there is some evidence that a circulating permeability factor is playing an important role. Based on kidney biopsy, there are different histological types of nephrotic syndrome. By far the most common form is called minimal change nephrotic syndrome, where no abnormalities are visible on light microscopy. However, on electron microscopy, as seen in this figure, it is clear that the fine finger-like structure of the podocytes becomes severely disrupted. This type of nephrotic syndrome has the best prognosis, as it almost always responds to prednisolone and leads to normal long-term kidney function. Another form, however, is called FSGS, and this is a much more serious form. It is often steroid resistant and can lead to terminal kidney failure. Generalized edemas is a fundamental symptom of nephrotic syndrome. The edemas are not localized as in the elderly, but are initially present in the periorbital region. Here you see a 1-year-old boy who presented with edemas around the eyes. This finding is often misinterpreted as allergic conjunctivitis by the general practitioner, who then prescribes antihistamines without success. Later on, the edemas also become visible in the genital area as scrotal or labial swellings. Ascites can also be present in severe cases, as shown in this picture. The development of edemas is associated with a significant weight gain. Despite the edemas, the loss of proteins can cause marked intravascular hypovolemia, seen as oliguria, fatigue, and abdominal pain. Hematuria is present in approximately 20% of children with nephrotic syndrome, most often, however, only as microscopic hematuria. This disease had a mortality rate of approximately 30% before pharmacological treatment became available. The urinary loss of proteins and thereby immunoglobulins increases the risk of bacterial infections such as pneumonia and peritonitis, which were the major causes of death. Also, urinary loss of anticoagulation proteins increases the risk of thromboembolic complications, for example, deep venous thrombosis. The first-line treatment of nephrotic syndrome is high-dose corticosteroids that usually bring the child into remission within 1 to 2 weeks. The treatment is then continued for a total of 12 weeks, and the long duration is necessary to prevent early relapses. Until the steroid treatment is effective, it is often necessary to treat the associated symptoms. The edemas are treated with diuretics, and in some cases, we infuse albumin to increase renal perfusion. High blood pressure is treated with antihypertensives, and infections are treated with antibiotics. If a child does not respond to initial steroid treatment or have frequent relapses, we often try other immunosuppressive agents such as tacrolimus. A new and very promising drug is rituximab, which is used in the most complicated children.